Well, thank you again for having me. I think when we talk about what does relational theory and approach to our clinical work have to offer, my bias is I think that the relational or intersubjective community has really, in many ways, redefined what therapeutic interventions have to offer, that sets itself apart from, let's say, our classical conception of what therapeutic action is and what treatment's about. So by redefining, therapeutic intervention and analytic posturing and a technical priority, personally, I think that the field is a breath of fresh air. It just, it's entirely different. It's an entirely different world than I remember back in the 80s and 90s. And, it's coming into the 90s, but from what I was taught, especially having undergone an analytic treatment with someone who trained with Bion, so entirely different perspective, entirely different feel than, let's say, what I experienced in that treatment. They more or less revamped the classical take on neutrality, on anonymity, and so-called abstinence. It was, I'm going to set aside the fact that we can interpret what neutrality really is, or anonymity or abstinence. I'm going to just set that aside because I have different interpretations of what Freud actually said in his texts, and however it was taught, or how it was metabolized by practitioners. So let's say that the caricature of the classical analyst is being displaced with the introduction of the relational perspective. Basically, I'm going to use this binary here as kind of as a way of making more of a divide, but in many ways it does seem to hold some water. That a relational analyst is more, let's say, personable. There's more of a feeling of authenticity or genuineness, or they're more humane. They're certainly more reciprocal. That's often being, pitched toward the classical person who's just, like detached, emotionally cold, or reserved, or socially artificial kind of a feeling that you have of this stoic person who's withholding, who says very little, and everything's thrown back on you. Once again, I'm using the stereotypes here. However, I encountered that. I encountered that with my own first analysis in particular. I encountered that with my professors and my supervisors, particularly when I was in Chicago, despite it being the town, Kohut, self-psychology. You had Merton Gill there, who was my supervisor as well, so the interpersonal tradition. But it was still in the backdrop, or the background here, is a classical feel. And I remember one of my supervisors down at the Chicago Institute that was just, well, the stereotype, like you come in, you're waved in to his office. He says nothing, no handshake, no words, sit down, have a seat. He comes over, sits down, and this is a supervisor, not in treatment, but he's treating me like I'm a patient. And so as a supervisee, that's uncomfortable. And this is supposed to be somebody who also trained with Kohut, so it's not quite the way things I wanted to go, but that's the way it was. So anyway, the thought here is that a new attitude, a new way of thinking about how do we work conceptually in an applied fashion in the consulting room. So what goes on in that little magical space is what we often wonder. You're reading the texts, you're reading I'm sure anyone who's read some of the classical texts, whether it be, from the Freudians or the Kleinians or beyond, in particular, I'm thinking about those folks. They were interpretation machines, like Pez dispensers, and the feeling that goes on by reading their works in the consulting room. I'm thinking, Jesus, would I like that? I don't. But when you're young, and particularly in your training, you're impressionable, and you're thinking, oh, this is what I should be doing or emulating. But it seemed so unnatural to me, sitting back. I'm more of an interactive person, personal guy, sitting back and saying nothing, showing, almost, it just goes against my personality, but this is what was expected. This is what the true analyst is supposed to be, like some detached ego or something that's out there analyzing with this kind of rational cogito that's separate from oneself and the body. So I think in many ways this is what the relational people were rebelling against. They didn't want to pretend that they had to act that way or should be that way, even though it was maybe in some circles political suicide to do that, because you didn't get into the club. Now, I've never been a person in a club, so I don't give a damn. But I can imagine that people who are up and coming and they want to be accepted, they want to be nurtured into the field, would feel that they need to act in certain ways in order to get acceptance or recognition. And anyone in the position of, having not being a separate professional where you have your own independent thought and freedom to do what you want, but we're under either your training or supervisory requirements that I remember I had to pretend, like become a false self just to get through a goddamn year with one supervisor in particular. I mean, this guy was awful. And I'm thinking, oh, but if I don't go along here, he's going to make my life miserable. And so it really encouraged me not even being able to be honest. I mean, I remember one case in particular, I had to bullshit my way through and say things about what I thought he wanted to hear, because I didn't have my doctorate at that time. I'm just almost done, ADD, doing my internship, but I was afraid. Of course, when you graduate and you can become your own self, you have more autonomy. But anyway, that taught me specifically how not to act, how not to be, whether it be as a therapist, whether it be as a supervisor. And so I was very, I very much gravitated toward reading Mitchell and Greenberg in the 80s, early 90s, before I graduated. So the feeling here is like, do we really know what goes on in the consulting room? No, we don't. But we got to feel that things could be different from, let's say, reading some classical texts. And, you got this sense that there's more dialogue and less monologue, that there's more attunement to the process that's going on in the dyad and less on interpretation. That maybe there's more emphasis on the affective experience that's going on over insight as the main goal. Doesn't mean that it's not a goal. It's just that there's, they used to even call, they didn't even talk about affect at certain points. They used to call it a drowning man. It's like as if it didn't exist. Well, it did exist. It existed ever since Bowlby introduced the primacy of attachment. But that, remember, he got airbrushed out of psychoanalytic literature. And it wasn't until just recently, like the last 20 years or so, that attachment theories come back and been gobbled up. Just completely taken in by the new movements and neuroscience and everything trying to amalgamate it. So anyway, other kinds of differences is that there's more interpersonal warmth that can be exchanged in the office, and it's more emotionally satisfying to both people. There's the notion that there might be some mutual recognition of two individuals, two subjects that's going on. That's a very, very powerful notion. It comes from Hegel's master-slave dialectic and the phenomenology of spirit, by the way, 1807. That the notion is that we can only come to appreciate who we are by recognizing ourselves in the otherness, in this context, of the patient. And it's not that I am a detached observer as a subject and there's the object of science that I'm analyzing as if it has there's no bearing about a relationship going on. So those were, I think, some important shifts. And then where does that lead us? It leads us to, well, maybe this is more about the focus on the here and now relatedness that's going on. And, to be honest, I had three analysis at various periods in my life, if I didn't tell you that the first time. First one was beyond trained person. Second one was a self-psychologist. So entirely different with that type of person than my first one. And issues around being empathically attuned, this notion of the need for validation. We can call it mirroring and all that stuff, but we do crave that. I think a human being wants to be, for lack of a better word, mirrored, but they want to feel understood. They want to feel that you are present, and that your presence, even if it's silent, is a relational incorporation of you. And that often isn't the case when analysis is defined as you come in with a prescribed set of artificial social arrangements. This is, I think it's important to say that, because nowhere, at least I'm not aware of it, nowhere do we have a prescribed artificial social arrangement than we do with the analytic encounter. If you take the classical approach, where we have an agreement that you come in, you lay on the couch over here, I sit behind you here, and you just free associate. and then I'm listening, and as the analyst, and I'm attempting to, listen on multiple levels for derivatives, and I point them out, and we're oriented toward understanding that intrapsychic life of the person on that piece of furniture over there. Well, nobody does that. We don't do that in real life. You don't have a conversation like that with friends even, let alone intimate people. However, everyone knows the value of that when you're doing that work. I mean, at least I know the value of that. There's a place for that. It's helpful. The notion of not having to look at someone's face, where unconsciously you're having to be tuned into every little microdynamic that unconsciously is telling you should be, tuned to that facial expression or that affect or whatever. That couch and not having that face-to-face does have a certain methodological purpose that has some value. But a lot of people, particularly in this day and age, they're not coming in for that. It's only people, it's like I said, a very small majority of people are seeking that out, and those who are often in training. They want to become analysts, so they go through the ritual. But the relational analyst may offer other tidbits. They're often face-to-face, whether it be chairs or couches or nothing or whatever. Not always, but for more, I think more than not, that's the way people work. They're not in there 3 to 5 times a week. They're there for more psychotherapy for a number of practical reasons, as we all know. And so those contexts and contingencies of why someone's there, what they're looking for in particular, changes the way we, have to relate to their needs and their expectations, not simply as professionals, but also from the standpoint of pragmatics, or from a business point of view. I mean, if you can't retain patients because you're not giving them what they expect by coming to see you, then you're not going to, be probably very good. So we have to be malleable and shift things for what the client expects, rather than expect them to follow a prescribed rituals that we think that they should be doing. And we all know that these are interpersonally negotiated things around goals, expectations, for why they even came to see you. Not to mention, in today's world, it's as if, you have to go through a job interview to retain a patient. Everybody's shopping around. We don't know what they're looking for. I mean, it's like before they invest and enter into this, they've already come to you. We already know that there's a transference going on before they even step into your office, or they wouldn't have contacted you for. There's transferential reasons for it. The other things, again, I don't know how everyone works, but people who value this notion of the analyst who's attuned, who validates, who shows humanness, who shows empathy, that seems to be a different portrait from the analyst who's listening for drive derivatives, let's say, the libidinal and aggressive wishes that are behind the client's utterances. And this, again, the caricature is that a classical practitioner is not going to gratify the patient's needs and demands. In fact, they just want to understand it, but by not gratifying it, even we know the purpose. It's to foster the development of the transference, so we can then try to understand the elements of unconscious projections that are going on and conflicts, in order to break down defenses and point out what's going on. But those things often they certainly can transpire with relational practice, but it seems like that the purpose is a bit different. I guess the classical caricature is the person who keeps their emotional reactions and their countertransference in check, while the relational analyst or practitioner, therapist, what do you want to call them, they're more likely to discuss their countertransference, let alone if they have the term these days is enactments. If something happens, let's talk about that. Okay, well, what was going on in me? There must be some internal conflict in me as the therapist for me wanting to say that, and let me look at myself, and I'm willing to talk to you about that. Now, of course, there's good and bad to that. There's some dangers to that, but there's also some incredibly honest, open disclosures that can take place. So just to give you some different reactions I've had with my previous analysis. My analyst, who was Bionian, had all kinds of countertransference reactions. I mean, just they were myriad. They were just spewing everywhere, and I wanted to address it with him. And the mere fact that I wanted to address it was just met with contempt, and it's my own narcissistic need and my egoism that needs to hijack the treatment, and that I'm competing with him. I said, no, I don't see it that way. Yeah, you're 40 years older than me. Yeah, okay, but you just fell asleep on me. No, I didn't. I did not fall asleep. I had to wake him up. This type of stuff. Things about fees, all kinds of stuff. So he would not want to engage in that. My last analyst was trained by Winnicott, and he was personable, but he was also a little bit, he's Scottish, a little reserved, a little back, and when I wanted to ask him about these things, he just basically said that I don't work that way, and he set the parameters, and at least it seemed more genuine that this is the way he is, this is how he works, and there are certain things we can discuss and certain things we can't. Okay, that's fine. I needed some containment, or at least I know the ground rules. Whereas perhaps by today's standards, the relational practitioner is like, well, anything's game here. We can talk about it. And I think this is where the differences come in among relational practitioners, because some are going to advocate for more fluidity and experimentation and permissibility and malleability in the treatment frame and in the topics discussed and how much you talk about yourself, versus a kind of tempered negotiation of what's going on between us and what you're willing to say and what you're not willing to say, and is the focus really about us, or is the focus on you? And this is where I think it's hard to tell from the literature how people really behave. Some are very open about it, of course, and this is what we'll get to today. It's also easier to go after people who are brave enough to write about what they did in the consulting room and take chances, which I really admire, by the way, even if I might not agree. They're also, the relational practitioner is more likely to be okay with talking about impasses, either in connectedness or the treatment. So anyway, the notion is their strength is to challenge these this uncritical traditionalism that has just been kind of, passed on by our ancestors, or the dogma around technique. And if, once one breaks out of any kind of hegemony or transference to, or countertransference to theory, then, you expect that we're going to start thinking independently and thinking critically for ourselves. What makes sense to us? What do we want to do or say, or how do we defend our positions or argue for our case? And so I think that's where I'm all for that. And it's gotten, I'll either be accepted or I won't. But people who don't have any tolerance for being challenged, who have a need to, think in a certain way, and they want followers, and they want a flock, and as if they're proselytizing to, the choir, are not going to like independent thinkers. They're not going to like people challenging their point of view. However, I would say that we have to be open to criticism. We have to be open to critique from within our school, not simply, tolerating critique from outside. The within is very important. This is where movements can take off into different directions. And if you have certain like cults of personality that don't allow that, whether it be in the formal institutional training environments that you are brought up in, or in publications, I think this is actually a danger to our profession as an intellectual discipline, not merely as a clinical discipline. So, trying to get an idea of what is this practitioner doing in there, even though it's secret, it's behind closed doors. We get glimmers from people's writings. We get glimmers from how they talk about their work to other colleagues. We still don't know exactly what goes on. And ultimately, I would imagine that it's our own personalities that are leading the direction of the treatment in some way, even if we're following certain rituals. The person, though, who's not interested in that traditionalism, but has a need to feel more connected to another person, may be the types of people that will come to the relational practitioner. People want to be related to in a genuine fashion, not in this, artificial manner, and not to act completely unnatural, like some frozen statue. I mean, so I don't think the frozen statue would. I don't see how they do very well today. Maybe they do. I don't know. Maybe it's just conditioned. Like, people get a referral, like, let's go see or hear, let's say, Arnie Richards. The Freudian is that way. I don't know how Arnie works, but maybe you're conditioned to anticipate and expect this is what you're going to get when you go to someone who's a Freudian versus the relational person. A lot of complex things that even bring people into your consulting room to begin with. I guess another thing that was the relational school capitalized on, particularly with Mitchell, starting with Mitchell, is that they take an entirely different epistemological approach to treatment. So rather than assuming that the analyst is, omniscient and is the one who's supposed to know, this gets challenged. So this objective epistemology is kind of turned on its head, where I don't know, I don't pretend to know, and only when we start to unfold things that we'll get a picture together, what might emerge in terms of what we can know about your inner experience, your life, your history, things like this. And that in and of itself is somewhat liberating, in the sense that I don't have to pretend to know as an analyst, nor do I have to put on a persona that that I know exactly what's going on in your mind, and by applying all these abstract theories. There's some dangers to that, and I've been critical of it too, because the extreme form is that I don't know jack squat. Everything is so subjective, and everything's subjective, and that means it eclipses any notion of objectivity. Well, that's ridiculous too. That's not the way things are. You can go to the extreme version of the post-modern or pomocentric view of knowledge or epistemology, and that you start to dismantle things such as what reality is. Again, this is a complex issue, and I don't mean to simplify it, but I'm just kind of accentuating the divide here, is that you go to the analyst who is supposed to know. They are looking for objective aspects of your psyche that materialize or appear in the treatment. They are offering modes of explanation, not just interpretation. This is important, I think, because the hermeneutical approach is to trying to interpret phenomenon. Whether or not we're getting at a pure description of things is another issue. Versus when we try to explain something, we typically, at least in philosophy of science, in logic, try to offer an explanation. And an explanation or an explication or an explanans is always basically a causal claim. It's talking about something that's ontological, something that's real, not just a fantasy, so to speak. So the one who's supposed to know, let alone who's the Gnostic priest who has unfettered access to truth, is to be questioned by the new relational movement. Now, while I'm thinking about it though, who in their right mind would go to a professional who claims to know nothing and has no expertise or knowledge or skills to offer? I mean, it'd be just like, talking to your neighbor. So there are expectations that you know what you're doing, or you've been trained. That's why I'm there to see you. And yes, we might not have the unadulterated access to truth, but we'll maybe stumble upon it through this process. And at least there are some objective facts that exist. And sometimes people who are too blindsided by their own psychic reality can't see certain patterns or themes or objective external dangers that are real. And they often are appreciative when you point these things out. And it reinforces the notion that, both subjective and objective processes are, intertwined and coexist, and they're on parallel levels of experiential development. So that whole thing about the subject-object divide is hard for me to hear, because you have extreme views, like everything's subjective. With the relational folks, everything is intersubjective. Everything's based upon a relational ontology, and this is problematic in a number of ways. Let me give you a couple quotes here. For instance, Seligman, this is his quote. He says, "The analyst and the patient are co-constructing a relationship where neither of them can be seen as distinct from the other," end quote. We're constructing a relationship where neither is seen as distinct from the other. Well, that's a ridiculous ontological assertion. I mean, you mean to tell me that people are indistinguishable from one another? Of course they are. We are quite distinguishable from one another. Let me continue. Here's what Mitchell says. Mitchell says, quote, "There is no experience that is not interpersonally mediated." End quote. No experience that's not interpersonally mediated. So that means then we're constituted, hence we're caused by these extrinsic forces that determine who we are. The focus on the relational matrix, or the intersubjective system, or the relational field theory, whatever lingo that you want to use, they seem to reify the analytic dyad as a third agency or a third subject. And a final quote. Ogden says, quote, "There is no analyst, no analysand aside from the process which generates the analytic third," end quote. That means it's a new agency that's been created. The third emerges. Well, this is a hypostatization of the system. It kind of makes it like a person, or what I would more jokingly call a macroanthropos that exists out there, that's making all these decisions about my intersubject, or my subjective life, my intrapsychic life. That's all being mediated by this third entity, if we're to go to that extreme. Well, no. This is why there's a lot of contradictions in the field. I mean, in the relational literature. I mean, you have people that say, "Oh, well, we don't displace the notion of the self or the subject." Well, you do in many ways by focusing on the third. And if you privilege that intersubjective system over everything else that conditions it, that defines it, when you say there's no experience outside of that's not interpersonally mediated, well, what happens to things that are more internally derived? like our natural embodiment, our desire, our wants, our needs, our conflicts. There's a number of things: affect, pre-linguistic processes, things that I wouldn't necessarily would say was generated by this third a system, or whatever you want to call it, that materializes out of this co-constructed relationship. Now let's be more generous and not go after the juggler. What's the true spirit of that? It's more like the analyst who says, we're really not here to have a relationship. We're here because of why you've come to see me, and it's about you, and it's about your experiences and your life history and your conflicts and what you want to get out of things. That's the focus. But the relational people say, but I'm a human being too, and we can talk about us. That's not necessarily the transference. So on one hand, yes, everything is transferential. Of course it is. Every time you lay your eyes on somebody, you might have unconscious receptors about how you've encountered people in your history that you would naturally filter through some kind of unconscious process that would then be projected. But it doesn't mean that there's not real properties about you or others or the world that don't solicit that or trigger it or invite it. So, like when Lou Aaron was talking in, I think, the Meeting of the Minds, but other papers, when he would invite his patients to point out his own internal conflicts that he thinks that he's not aware of, he's not has privilege to, because he's a human being too. One could say, well, that's very generous of him. He's opening himself up to having a mutual dialogue about his own internal life and how does it play out in the treatment. However, some people might appreciate that, enjoy that. Other people might say, yeah, this seems to be more about you than it is about me. And like, to what degree is I have to attend to your narcissistic needs in here when I'm paying you $250 an hour, or whatever, the fees are. So anyone who's treated personality disorders, especially narcissists, the last thing they want to hear is something about you. I mean, it's just like, it's enough just to set off a rage. So to assume that everybody has the same needs around what therapy should be about, that all treatments would unfold the same, we know that's not the case. Getting back to other refreshing aspects, though, of the relational turn, that in many ways it encourages free thinking. Not think the way I want you to think or act the way I tell you to act, but we can have an open, indeterminate discussion about something without superimposing an end process, and we'll see where it takes us. So encouraging that kind of freedom in the treatment, I think it's empowering to a person's agency or a sense of self, versus the whatever you say or do, this is how you treated your father when he would do this or whatever, and you've reduced things to a genetic level, based on history, based upon Oedipal acting out, or whatever it might be. Again, when I'm thinking about it, those kinds of deep interpretations, the Strachey interpretations, they often they commit what's called a genetic fallacy. There's the assumption that certain events took place in your history, let's say even going back to in utero. I mean, the Syria that Freud talked about and Bion talks about, the notion that everything you do could be genetically traced back to an original cause, and if we just get the right interpretation or configuration around it, you'll have some insight. That never happened for me. And the notion is that in psychic life, everything's overdetermined. But if you were to try to go and say this happened, to you at 2 during the anal stage, you have penis envy and all this stuff, that would be so antiquated, I think, in today's world. But who knows? I mean, people may get a lot of insight out of that. To me, it's genetic fallacy. The other thing about free thinking is that the analyst also can experiment freely. So not everything is rote. Not everything is set in stone. Sometimes we have to experiment with certain techniques or with certain personalities that are negotiating a certain dance, that there's an openness to novelty. There's an openness to spontaneity that, more subdued or conventional approaches to treatment would not really encourage or foster. They might do that, in their actual treatment. We just aren't there. They're not writing about it, though, at least not what I've read. Other advantages is that it can lead to different forms of creativity. And, how do you creatively play with certain internal experiences or ideas? How are they symbolized? How are they come to be understood? How are they integrated? This also opens up a permissible space for being more authentic in your own self-expressions as a therapist. How you wish to be. Now, this is not always easy, of course. But also I get the sense that there's more humor that takes place. There's a playfulness that's permissible, if not encouraged. And not only that, but there's the encouragement of the analysts to examine their own vulnerability. And whether that be as a person or as a clinician. And, talking about their own self in relation to what's going on in the treatment is certainly fair game. So in many ways, I see these as the relational school's greatest contributions that are over, let's say, classical technique that's in many ways, whether it's designed to or just is a corollary, that it leads to the intensification of feelings around, feeling rejected or shamed or guilty or provokes rage in the service, quote, of the transference. When someone's deliberately withholding, they don't want to say anything, again, abstinence or neutrality, that's a lot, again, it's the way that the relational intersubjective folk have wanted to characterize this classical person. And it's not always fair. I mean, like I said before, it could be they're set up as a straw man argument. In reality, they're not really that way at all. Neutrality is the notion is like they just don't want to interfere, or they're going to take a genuine interest in whatever you have to say, and not necessarily have a judgment that's placed on one aspect of the association over the other. Or the notion of anonymity is like, it's important that I don't just project my own subjectivity and talk about my own life, because this is really more about your internal process and trying to understand what's being stirred up for you, and how this relates to, let's say, repetitive patterns of conflict that get you in trouble, or that you find yourself in some kind of repetition of. We understand it, but of course the person who is so withholding and cold and is the tombstone can, when they're not going to validate you being a human being and you need them, that could easily lead to rage, and if not them just bolting from treatment because they feel they've just been so mistreated. So this is, I think, the good stuff. The good stuff that this movement's introduced. In fairness, though, the difference in reality, I think, the difference in these techniques may simply be a matter of emphasis. That at certain times, you're going to be much more invested in trying to understand, let's say, a repetition compulsion, or how certain defenses are circulating, reinstating themselves, and that person is just blind to these patterns, these defenses, and that goes on in a relational treatment environment, no different than it would be in more traditional treatments. Now, the criticisms of relational technique. I'm trying to be fair here. How would both parties, meaning both sides, try to characterize this? Well, the more classical people, and it doesn't mean that classical people aren't object relations people, by the way, or self-psychological too. But they would say the relational techniques they're not focusing on the deeper stratifications of unconscious structure and those dynamics that are operative there. It's more in the here and now. It's more about consciousness. So that's one, I think, valid criticism. The emphasis is much more in consciousness in the here and now within the relationship. Another related criticism would be that they largely are failing to focus upon someone's genetic past and their history in favor of the here and now. And they're not looking at the symbolic manifestation of the transference as much. But it depends what you call transference. I mean, genetic or past transference versus the here and now transference. That another criticism, again, around unconsciousness would be about there being inattentive to unconscious fantasy. What's the, what are the fantasy relationships that someone has when they're relating a story or talking about others, or failed or thwarted wishes or desires, things like this. Maybe that's not the case, but maybe this is this is certainly what some of the classical people said. One thing that seems to me to have a truism to it is that the relational person's too permissive in maintaining this kind of permeable treatment frame. Like the treatment can just meander in and out and do this, and we'll just all, deal with it together. And there's that lack of a containment or frame. This is where Robert Langs would be turning over in his grave, seeing the lack of the frame. Now, well, if anyone's read Langs or knew Langs, which I did, I could see how somebody would want to murder him. Just such a rigid, superimposition of the way you should be. But he really was great at making you think about listening for the unconscious communications, listening for the derivatives, for the projective identifications, things like that. I got a lot out of his work. The other thing would be, again, lacking a contained and well-defined boundaries. And this includes rules about consensual participation. So, when people don't know expectations or frame or the norms of engagement, rules around discourse, that it can unearth all kinds of ambiguities, which of course we deal with all the time. But it is different from accepting this ritual. This is what we do. We come in and we acknowledge it and we participate in it. And this is the expectation that we both have, versus there is no expectations. We'll just deal with whatever comes up. Dealing with ambiguity or being able to tolerate it. In many ways, that's I think where we find ourselves in real life. You have no idea what kind of patient you're going to get when they come in, unless you do an assessment. I mean, I don't even screen people. You come in and I don't want to hear anything on the phone. Making the appointment, and we'll get into the details when you come in. And so I don't know what the parameters of the treatment's going to be, and I don't know anything about this person, and I'm, floating out there just like they are. And then something comes of it. At least through the consultation period, you'll determine whether or not you want to work together. The focusing too much on the here and now is, of course, the big criticism, and the even bigger criticism is that that the focus is on co-constructing a relationship rather than exploring someone's intrapsychic life and their past. I guess I don't know what the relationship is. What is a relationship? What are the different levels of relationships that could develop? Some of the people in the field, the relational literature, seems like the expectation is that we're going to have a mutual kind of analysis or a mutual openness to talking about our lives and our subjective senses of self, and that we're going to share cliff notes and things like that. And that's not only expected, but it's coveted. Whereas other people, it's more about, of course, we're going to talk about us when it comes up or when it's appropriate. And, talking about us is part of any kind of human relatedness. So just like you have problems, interpersonal problems with your family members, your spouse, your kids, your co-workers, it's going to be replicated in here, and I'll bet a 20 on it right now, because you're impelled to repeat it. So I'm not so sure that the relationship issue is been absent in traditional or historical models. It's just maybe a different emphasis. And I would imagine every single practitioner is in charge of, deciding how that should be crafted or how much of themselves they put out. But this is where it opens up the question about therapeutic excess. And basically, how do we know when there's too much, when we've gone overboard, when we've done more than we should, say more than we should say? And I don't have the answer to this, to be honest. I think just even talking about it is important. Having an honest discussion, because if you can't be honest, including talking about not knowing, talking about blunders, massive screw-ups that you've had, countertransference enactments that have just, boiled over, and if you can't talk about that, we're not going to learn from one another. And so what's customary in a lot of analytic writing, and this is across the board with all schools, I don't think we have a monopoly on this, is that you read the paper, it's got some theory in it, it's got certain points that it wants to make, it shows clinical vignettes, it shows the intervention, and in the end, all of it just kind of meshes together in a cool way, and you go, yeah, that sounded like that worked out pretty well. You don't get, I fucked up, it led to this horrible thing happening, I don't know why I opened my mouth to begin with, but now it's gone south. No one wants to talk about that stuff because they're afraid of being judged by their colleagues, or reproached or devalued or made fun of or shamed, which of course we do. We do it all the time. We love to gossip. We talk about people behind their back all the time. And there's something about that maybe it has to do with just our profession, being isolated, working with people, not working in other work environments that are on teams and interpersonal. But in fact, I'm so guilty of it. I can hardly wait when I go to conferences to see my friends and colleagues who want to tell me about things. That I just feel a sense of voyeurism or intrinsic pleasure hearing about other people. The point, though, is how much self-disclosure is permissible, is good. Of course, the undisciplined use of self-disclosure, I feel, is not an ideal. And I don't know if there's a standard. Is there really a norm that we can compare ourselves to that we should be trying to emulate? No, because everything is contextual. And not only is it contextual, it's also based upon that you're a subject, I'm a subject, or self, whatever you want to call it. No, we're not fused as some kind of merged entity. No, we're not this third agency that's symbiotic. No, we're not. We're completely different individuals. Yet we might participate in certain processes that are universal to being a human being, and we have to kind of negotiate that. But at the same time, this thought of that there's two subjects that are mutually analyzing one another, like like frenzy, for instance. Again, that may not, probably is not fair to say that, because that was way back when psychotherapy was just beginning to be defined. However, they did open up all kinds of excessive forms of experimentation were by these early pioneers. We're all aware of them. Jung, Otto Rank, Frenzy, Grodick. I mean, they all had sex with the patients. These kinds of things are not permissible, but given that that was a different time era, we can learn from those mistakes. However, this is where the past keeps seeming to come back. It can bite us in the butt. We have to have very clear ideas when we're talking about sexuality with clients, about what is permissible and what's not. So, too much self-disclosure, let alone self-revelations, can be damaging. But how do we judge it? How do we know when something would be received well, and when it would be received in a traumatic way, let's say? On one hand, the relational practitioner is much more comfortable and open about talking about their countertransference reactions or enactments. On the other hand, by doing that, where does it lead the treatment? Does it facilitate it? Does it help it? Of course, uninhibited risk-taking or uninhibited experimental practices, for the sake of which we don't know what's going to happen, let's see, probably don't end very well. It's hard to know. Clearly, when there's boundary crossings, let alone breaches or violations, we might say, we can step back and say, yeah, that shouldn't have happened. You should not do that. You should not be kissing your patient on the lips. You should not be letting your patient sit on your lap. This is what Frenzy did, by the way. To what degree do you introduce a client into your own personal private life? Well, a lot of the times we're all in the same profession. We run in certain circles. You're seeing therapists. How do you establish those boundaries when you're in the same profession? This is where the context and the contingencies often dictate what is permissible, what is safe, what's not safe, or at least questionable. So what's legitimate? What's a legitimate execution of an analytic method? Now, the question itself begs the question on therapeutic action. What makes something therapeutic? And obviously, there isn't just one thing that we would do or say or act that would determine that question, let alone the outcome. Does a frank and open discussion about the therapeutic relationship, the relationship between the patient and the analyst, or the therapist and the patient, client, whatever you want to call it, where does that go? If you say nothing is off limits, we can talk about anything. Well, this is where this is where I think problems can happen. things can go awry, especially if you start getting into feeling comfortable about just free associating to what the patient's questions about you are. I mean, I'm just as guilty of this. I've done all kinds of things that I felt were important to the client at that moment or that time, but I think I've had certain boundaries that I'm just not gonna cross. But it depends upon how you would judge it. I'm thinking of two patients in particular, and one of which, well, they both were very severely traumatized individuals. One attempted suicide, and I went up to the hospital, and he was on a gurney, almost in a coma. He was a big man. He was like 260 pounds, 6'4". He drank one of those half-gallon of vodka bottles, the one that has a handle on it. And he's just lucky he didn't kill himself. And I ended up feeling the need to go to his wife and his daughter that night at their house. I visited them at their house to try to help them deal with things. I visited him in the hospital the next day. I brought him, lunch, stuff that I did. I went out of my way. I felt it was my moral duty to myself and him. Nothing negative happened, but that was one thing that somebody said, "Whoa, you really went overboard there. Your countertransference is out the roof." And another person, I took him to the hospital. I loaded his dogs up in a minivan and took his dogs to a kennel, packed his stuff. We went to the store to get him some toiletries, and I checked him in and made sure that he was going to be safe. So, because he had tried to kill himself so many times that I just didn't want to take any chance. So I've done some extreme stuff, but there are certain things that I haven't done, and I guess this is up to us as clinicians to decide how far are we willing to go. On one hand, like I said, it's courageous for people to discuss openly and honestly their cases in the literature, because we get a feel of what's happening there. And let's not assume that it's all doctored up. Some of this stuff, maybe, I think a lot of people, when they write, they probably just embellish shit. They might even lie. And they'll probably say, "This is what I should have said," rather than what I did say. But I don't know that. But what I do know is that people do lie about how they present themselves. And having worked with a number of researchers to do that, they'll cherry pick data, get rid of things that they don't want in there because it's an outlier and it will go against their position. So they manipulate that data in a way they produce the stats they want. I've seen people like that. And I work with people like that. But by talking about things that others aren't talking about in terms of their disclosures, that I think that's very, very progressive. Now, it dispenses with this dishonesty among colleagues. If whoa, that was a tough situation to be in. What would I do if I was in that situation? This is what this person did. But it can lead to the potential misuse of technique. I think there's a danger of being overly personal in your communications and self-revelations, but it depends upon what it is. And so if the person, I mean, the therapist is there who insists on their own revelations as part of the treatment. Like, this is just what I'm thinking or saying or what I'm feeling right now about you, about that, and then that leads the treatment more into the direction of their own process. To what degree is that in the service of the analyst's narcissism versus what the patient really needs? Now, I'm leaving that as an indeterminate open question. I think, one person's, I mean, we wouldn't be in the profession if we weren't getting something out of it. So, I mean, let's not pretend that we don't have our own narcissistic needs. Just the way they are played out or enacted in professional space is a different issue. I've often wondered, do you need to discuss the details of everything that's going on in your mind, in your experience with the patient? Do you have to do that? To what degree do you want to tell them explicitly what you're thinking in terms of, your countertransference reactions, or, being sexually aroused by a patient? Is there a place, let's say, that's taboo that one shouldn't get into? And keep it focused on them, not on you. I'm not sure there's again a clear-cut place that we could say this is permissible and this isn't, depending upon what happens. But what I found in the literature when I'm reading some of these sometimes seem like confessions by relational practitioners, it's a lot easier to be critical. And again, I'm saying this let's critique it to learn something, not just to tear them down. So would under any condition it be appropriate to violate a patient's confidentiality with another patient, and that those patients know each other? Well, I guess I'm told, I'm told by a lawyer in the province of which I practice, that would lead me to have a potential complaint against my license, or I could even get a lawsuit by the privacy commissioner, or by the patient themselves. So that kind of imposition tells me I have to play within the parameters of the game rules that have been established. However, we all know that legalities and rules of ethics are not the same as what is right, what is the right thing to do, or what's moral, or what's appropriate here, or how do you interpret those parameters? I guess I think everyone's probably quite aware of Jody Davies being the poster child for erotic revelations in some of her writings. And is it appropriate to discuss your own erotic feelings for a patient? I mean, maybe this is not a no-brainer, that it would be appropriate in some conditions. I'm just a little bit conservative. I'm not sure me talking about my lust for my patient, let alone details about my sexual fantasies for the patient, is going to lead to anything good out of this discussion, let alone engage in flirtation and mutual seductions that some people write about. Well, I know for a fact that would get me in big trouble up here, because they have what's called the Regulated Health Professions Act, and even talking about sexual matters could be interpreted as sexual abuse under the code, even though you didn't touch them. I mean, if you just start saying, yeah, I have fantasies about you all the time. Every time you come here, it's left me this and da 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 da. I'm quite certain I wouldn't still be sitting here practicing. How about lying to patients? There are people who talk about their own. They felt a need to lie just to get someone off their case. I think one was particularly that I read about is John Fredrickson, who's talking about screaming at the top of his lungs while invading his patient's space, right up in his face. Now, however, if anyone's worked with floridly psychotic people who are out of control, sometimes one has to be that directive. I remember in particular, somebody just would not be quiet, and I'm saying, I'm speaking now, I'm speaking, just so they stop. Now, somebody might say, God, you are out of control. That was aggressive. But in the moment, it felt like I had no other option unless I were just going to, walk away and let them calm down. The thing is that could this just lead to a wild analysis where just anything goes, kind of Wild West, situation? But keep in mind, before I stop for questions, there are many, many, many analysts in the history of the movement that have done things or said things, written about things that are quite controversial. Like beyond it's just, again, the interpretation machine to psychotics, who he's trying to interpret the content of their delusions to the point that it could lead to a fragmentation. Or Melanie Klein, interpreting the 5-year-old boy wanting to have sexual intercourse with her. Or Lacan. Lacan's, variable length sessions, where he just cuts somebody off in mid-sentence and say the session's over. Of course, leading to his excommunication from the analytic community and being blamed for the suicide of some of his patients. But keep in mind, he was working with psychotics and very difficult people. There's a whole history of experimentation. So this is where we're at. To what degree is something excessive? And I'll open it up for discussion now.
Candace, please.
Just to kick this off a little bit, the one thing I kept listening for, and I'm not sure I heard it, or at least not that distinctly, it seems to me the best guide in all of this, or at least an extremely important guide, is the patient themselves. Not necessarily entirely what one was trained to understand, or what one feels might work, or whatever, but what you're learning from the patient and the patient's responses to what you do. But I would think, first of all, talk about disclosure, for instance. The dynamic that you understand of the patient is going to begin to be a very important guide. I think, for instance, about Harold Searles, who was constantly talking about how he felt and what his reactions were. Because with his schizophrenic patients, as he understood it, this was the only way how the patient was feeling would be initially expressed in words, because the patient was projecting it onto the therapist. And the therapist was really expressing it for the patient. So in that case, and it worked, by the way. In that particular case, for that particular dynamic, and hopefully a youthful response, being quite self-revelatory was important. Although I might add, it was a selective kind of revelation. I think Searles felt that he was expressing a projection on him rather than his own impulses so much. But surely, then, whether you're heading in the right direction or not, a lot of it has to do with the way the patient responds to you. Whether what you've done is coming out of the way that the process has been moving, and then if the patient has responded to it in some way that indicates to you you've overdone it, underdone it, missed the target completely, or whether there's been that particular emotional contact, when there's been an interpersonal experience, which is one of the few ways you really do get that emotional response that isn't just an intellectual insight. So all I'm saying is the patient's here too.
Absolutely. I guess that's the most important thing. That's why you're there, and that's why they're there. I would imagine, again, working with a psychotic population, schizophrenic population is entirely different feel, entirely different way of working. And I actually, a couple of my edited books was on, one was on outpatient treatment of psychosis, and the other was on Lacan and psychosis. And I was surprised to see how many Lacanians, I mean, we all seem to be doing the same thing when we're working with those populations. We're much more active, entirely, even though you have different theoretical orientations, you're taking the lead from the patient. So yeah, I agree with everything you said, Candace.
John, I want to add just two little pieces with respect to the question you raised regarding confidentiality, and then leave the issue still as a question. There are two exceptions that are notable that you're aware of, but I just want to get it on the record, which is one, when the patient has expressed the wish to kill somebody. In this country, we have a case law called the Tarasov case. You probably are well aware of it, in which a psychologist reported to his supervisor, a psychiatrist, that a man was going to kill this woman, Tanya Tarasov. And the psychiatrist said, well, don't do anything about it, maintain confidentiality. The man then killed the woman. The psychologist was found to have acted properly by talking to his supervisor, whereas the psychiatrist was found to have acted improperly. So we now know that under those circumstances, the right to warn is necessary. The other circumstances would be if a person wants to kill himself or herself. In those circumstances, you might have to say something to somebody at some time. Other than that, I think it's still an open question, so I want to leave it on the floor.
Yeah, we have even more restrictions up in Ontario, where we have mandatory reporting obligations for children if we think that they're in danger, where we have to call child protections. If we find out that a previous patient had a a relationship outside of a professional one, like a sexual relationship, with another health professional. We have to report that. They even have a new one now where if you are aware of or suspect elder abuse, that you have to report that. I mean, it's getting a long list now. We're the new informants, as Bolus would say. Claudia, you had your hand up.
Sorry, it took me a while to find my mic. Hi, I enjoy the way you teach. I think that it's very open and you do cover a lot of ground. So last week I had a question, but it took me a long time to come up with a question. Then I'm kind of moving on now with today. But I think there needs to be a balance. I mean, and yes, it's like a sort of like there's no clear cut, right? It all depends on the person. And I think that, you know, so there, you know, I personally, I'm very careful about disclosing or even going to talking about some kind of sexual fantasy towards the patient, because that can lead to a lot of things. So I stay away from that. But there could be a reason why somebody thinks it's therapeutically appropriate. So, but I also know that, well, more and more they keep on talking about the felt experience, which is what happens between you and the patient, or you and the client, however you want to call it, which is so important because it's like what you were saying, the affect, being able to be creative, sort of going with what's happening there, the here and now. And then, you know, and that's great. And I love it. And that's what a lot of us do anyway. And then I think that the classical is important too, because it teaches you the theories behind it, and it helps you think and stay open, right? So I think it's a balance, but I love everything you're talking about.
Well, yeah, the balance definitely, you know, taking the lead from the patient, as Candace was doing, and you know, to what degree do you find a middle ground, maybe. But boy, I would imagine a lot is determined based upon your personality and your cognitive style, your attachment style, whether or not you're, you know, to use Jungian language, you know, a certain typology, certain psychological types. And you know, some people are just much more cerebral. Others are more intuitive, more imagistic, and they can connect with people in different varieties of clients in different ways. Mm-hmm. We have to be open to finding that balance in ourselves.
Could I ask a question?
Yeah, Leanne. Yeah.
Thank you. Thank you, Jon. Interesting as always. I want to say, you know, what Candace and Claudia mentioned about, you know, being where the patient is in the here and now, kind of letting the patient be your guide, makes me think of Jody Davis's paper, Love in the Afternoon. And I think it's such a great example because she seems to anchor it in the context of the dynamic exchange that has transpired throughout the treatment that is full of erotic sexual discourse. And it seems to be certainly relevant to the patient. And I think she makes a really good case for that very extreme disclosure that she made, that it was guided, in fact, maybe, you know, by the patient's need. I mean, on face value, it seems extreme. I don't think I would be comfortable doing it, but I think that whole case is a great example of what relational clinical work is kind of about, and what is the guide. You know, because I think as you're talking, it's really hard to define relational clinical parameters, but I think there are some, and yeah. So anyway, I'll turn it back over to you. Thanks.
Yeah, I mean, I think I've written about Jodi in the sense that I admire her, and I think she's brave about it. At the same time, critiquing it, and it's easier to critique someone's work when they put it out on paper like that, and you don't see that. And so, on one hand, that extreme form, but as I recall, the case didn't seem like it went well with that intervention. You know, the kid freaks out. My guess is that he was probably maybe a graduate student or something. I don't know. She doesn't say. She also doesn't say whether or not the person would like bolted from treatment. I guess when we end up with the scenario that he's bawling his head off, he's pounding his fists in his hand, and he's like in a little fetal position, and then he gets enraged and accuses her of, you know, needing to be turned into the family services for, you know, what she's doing. And I just wondered whether or not he stayed in treatment. We don't know. So I don't want to be critical of her. She opened up a space that we're still talking about now, and probably defined her entire career. I believe she gave an interview with Israeli psychoanalyst Nir Govran, who was a friend of mine, he told me that she, in the interview, said that, like, that's kind of defined who I am now, that paper. So
John, why do you think she stopped the paper where she did? I would have wanted to see more of the resolution of it. It seems incomplete.
Yeah, I think she ended it by saying that she felt that she was working through her countertransference, when I read it as an enactment of her countertransference, and that she leaves it where she says something like, sometimes we must speak the unspeakable. And I think I say, must we? I don't know. Must we say that? But not to negate the important point that Leanne was making, that the whole treatment was, you know, tinged with these, you know, the sexual overtones. And I think we have to be generous to any clinician that they're reasonably intelligent people. They're going to be making their best clinical judgments in the moment. And sometimes these situations are just so unpredictable that things happen.
But, you know, in later writings that she's done, like in Psychoanalytic Dialogues, when she's talked about disclosure, she's defined the parameters of it pretty distinctly, I think, in saying to do so only if you work it through with the patient and for the patient's best interest. And yet in this paper, she does none of that. So,
you know, if I may, I was thinking that she left it unfinished because it was evident. That's how I read it. It's interesting because I was thinking she had explained that he had a tendency to be masochistic in terms of his sexual desire, and that I saw his reaction as being an indicative of that somehow. His tension and pounding his fist, that it somehow was a reflection of that. So I guess it could be interpreted in many ways.
Mhm. Well, just to throw in a plug to thank Jody for giving us that that narrative, so we have something to talk about. Okay, I guess our time's up. Or any other afterthoughts? Well, thank you everybody again for an enjoyable evening. And I guess I'll see you next time.
Thank you all for coming. Take care,
Thank
John.
you.